right. Well, I think that we still have a couple more people joining, but let's get started. I want to say thank you for coming today to our fourth CPH review session brought to you by the National Board of Public Health Examiners. My name's Ashley Mueller, and I am the Manager of Educational Programs. So we're excited that you're back. So as in the last few sessions, I'll be monitoring chat and the Q&A throughout the presentation. The chat is open, so you can interact with your fellow audience members, as I assume many of you already are. And if you have a question for our presenter, make sure to use the Q&A section so that we see it. Our presenter will be answering any of those questions at the end of her presentation. Also, I know that some of you are very excited about our APHA CPH exam review guide. So our last winner for last session was Michelle Clayton. So congratulations, Michelle. We will be raffling off another copy today. So those of you who are here live, you are part of that raffle. All right, so getting to our topic today. Today's topic is health equity and social justice, presented by Alexa Meinhardt. Alexa has her Bachelor's of Art in Biological Sciences with minors in Psychology and Public Health from the University of Delaware. After working for a year at a local health system, she earned her Master's of Public Health in Epidemiology from the University of Pittsburgh School of Public Health, where she conducted novel research in the field of aging epidemiology. Alexa then joined the Delaware Division of Public Health as an epidemiologist, where she served in several roles focused on the infectious disease, emerging medical services, and preparedness and population health. She also played a significant role in Delaware's COVID-19 response activities. Alexa is currently an environmental epidemiologist with a human safety team and regulatory sciences at Corvera AgriScience. In this role, she supports the development of broad-based strategies and related to the environmental epidemiology and human exposure characterizations. Alexa is certified in public health and a candidate for the Certified in Climate Change Professional Program by the Association of Climate Change Officers. So also, a fun little fact, Alexa enjoys cooking, baking, knitting, and participating in various book groups. So with that, I'm going to turn it over to Alexa for our presentation.
Okay, thank you so much. Hi, everyone. Really happy to be here. And I see so much activity in the chat. I am based in Indianapolis, and I saw at least one person said that they are in Indy. So hello from the Midwest, finally warming up here. So let me go ahead and get my slides shared, and then we can go into our content. All right. All right, and just confirming it's now in presenter mode or like presentation. Yep. Okay. All right, let's get started. So welcome to today's session. Thank you for having me. Really pleased to be here. Congrats on taking this step in your journey to become certified in public health. I know that there have been a couple sessions previously, and there are several more to come. So really awesome that you are able to attend. I have adapted this slide deck from some materials that were shared with me by the National Board of Public Health Examiners to prepare. I delivered a similar version of this training to a local health department last fall, and so hopefully we will have a good session today as well. So I want to start with just some housekeeping items about the exam, and then we'll go over sort of an agenda and some content and get into it. You know, since we're here today, I wanted to take a moment to reflect on you know, why you're here to take the CPH exam. So some of you, that answer may be more front of mind than for others. And I'm sure everyone has different reasons for doing it, but I wanted to share some of my own. I think it's a great way to stay up to date on public health practice, no matter like your discipline or what your focus in this specific area is. I think it provides a really nice continuity and that sort of like sense of a community. You can use it to further your education. So whether you have formal training in public health, on-the-job experience, or perhaps a combination of both, what I really like about being CPH, one of the things I really like is that I, take time out of my work schedule to attend webinars or engage in other activities to become recertified. So it's this like built-in opportunity to maintain, awareness of what's going on in public health, which, as we know now, we all know this, but as is seen now in the public as such a vital, industry and field. I think it also gives you a competitive professional advantage. Being CPH shows your commitment to the field, and to the point above, you're constantly in the know of what's going on in public health and in those areas. And I know I've been in situations where I've been the only CPH, and I think that does show, employers or other people that I am demonstrated to continued education. There's an awesome community. You can participate in a book club where you read different public health focused books, engage in discussions and things like that. So, even though it's a largely virtual network, you get that sort of sense of common ground. And I think it provides this thread of continuity across jobs, education. So maybe as you're, transitioning from job to job, or maybe going from grad school into the workforce or what have you, this is an element that stays with you throughout your career. And then there are great networking and other professional opportunities like this. I had no idea last year that I would be able to present, and now here I am. I've also had opportunities to help write items for the CPH exam. So there are really good ways for you to grow and learn, not just literally in the discipline of public health, but also as a professional. And so if you want to read even more about why, I've included a link, and so you can find that on the website. Okay, and just to step back, some exam logistics, which I believe have probably been covered before, but to go over them briefly, 200 multiple choice questions, 175 of them actually count towards your score, and then 25 are sort of like beta tested questions. You won't know which is which, so you answer all 200 of them in a 4-hour time frame. Now, the score needed to pass does change with each new exam, but I can say I took the exam a couple years after finishing my graduate training. I watched the webinars, looked at the materials, and felt very well prepared to take the exam. It is single best answer, so the questions really aren't designed to trick you. It's not, A and B, but not C, or check all that apply. It's really, what is the one answer that best answers the question, what's the definition, what's the application, or things like that. It is online. You can take it like with a proctor or computer-based at a testing center. And then, please visit the website if you have additional questions. All right, so there are 10 domains in the CPH exam. Each domain is represented equally, so 10%. We're focusing today on health equity and social justice. So we're going to cover what health equity and social justice mean. Let me not advance there, as well as several theories in this area. And then we're going to finish off with some questions. There will also be some opportunities throughout for interactive like Q&A or some sort of discussion. And I'll get to those slides, and we'll be able to chat more freely. So just at a high level, a couple topics that we're going to cover. So, population health, health equity, social justice, and then really the last, half or 2/3 is going to be theoretical frameworks. And we'll go through all of that, and then have plenty of time at the end for Q&A, both what you as the audience have asked about, and then also I have prepared some questions, and we'll go over what the right answer is and also why some of the other options are not quite what the correct answer is. All right, so just as a reminder, take notes, jot down your thoughts, your questions, your comments, and then feel free to add them into the chat or the Q&A. And I find that, sharing concepts can also help educate others. So, please feel free to share your thoughts and your comments with your colleagues who are on this training. And hopefully I will get to learn some new things as well. All right. This is a busy slide. I'm going to do a lot of talking in this one, but really I'm just starting, big picture up front, population health, just going to set the stage here. So when we're thinking about public health and population health, A good place to start to really grasp what public health does is to look at Healthy People 2030. So these data-driven goals are set for each decade. So in the next, so many years, we'll be setting goals for 2040. These overarching goals highlight the complexities of prevention and health promotion while emphasizing health equity, health disparities, social justice, and the importance of the social determinants of health. And I know I'm throwing a lot of terms out here. We're going to go through and work through them, but just again, to get you thinking. So to begin thinking about health equity and social justice, we have to define some key concepts. And we need to think about the shift in public health from addressing the acute, what's right in front of us, to really moving upstream and addressing the root causes of health disparities in our nation and globally. And the mission of public health, you can hear it in slightly different iterations, but really it is the fulfilling society's interest in assuring the conditions in which people can be healthy. So wanting to achieve that optimal health. And with that in mind, social justice is defined as justice in terms of the distribution of wealth, opportunities, privileges within a society. It's the view that everyone deserves equal rights and opportunities, and this includes the right to good health. So it's this mentality carrying with us, everyone deserves the right to good health. Health equity is a term that public health practitioners use to describe the application of social justice principles to health. So when we talk about health disparities, we can think of these as a symptom of the social determinants of health, and we'll talk about those more, which are brought on by a lack of social justice. So this brings us to health disparities, health equity, health disparities. These are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by historically and systematically disadvantaged populations. And we'll talk a little bit more about why we measure these in a bit. We know that some populations experience disparities at greater rates than others. These can be observed by race and ethnicity, gender, sexual identity, education, income, disability, geographic location, and what have you. And then finally, social determinants of health, that really refers to the biological, environmental, behavioral, organizational, political, social factors. They're major drivers behind public health issues. And we'll spend some more time on that later. I also want to briefly mention racism and its different forms. So racism involves one group having the power to carry out systematic discrimination through institutional policies and practices of the society, and by shaping the cultural beliefs and values that support those racist practices and policies. And when we talk about it, there are multiple levels. So individual, that's interactions between people; institutional, within institutions and systems of power, and specifically the ways in which institutions create policies which create different outcomes; and then structural or societal racism, which is across institutions and across societies. These dynamic processes create cumulative and durable inequalities based on race. All right, I know that was a heavy slide, so we're going to keep moving forward. Again, that was just to help orient you. All right, let's start breaking it apart piece by piece. Health equity. It was defined by the U.S. Department of Health and Human Services in Healthy People 2020 as the attainment of the highest level of health for all people. The attainment of the highest level of health for all people. This relates to fairness, so no one is denied the opportunity to be healthy. I think this visual does a good job of really highlighting, quite clearly what health equity is. So you can see that both individuals on the left and right have attained their best health possible. They're reaching for that. They have it. And one individual is provided a tool to be able to do so. So equity is, again, highest level of health for all people, and where the conditions are there such that people are able to do that. And it may look different. So it's not the same, but it's fair. It may not look the same for everyone, but it is the application of those fair principles to allow everyone to achieve the optimal health. So in order to measure our progress in achieving this goal of health for all, we use health disparities as a metric. Health disparities are preventable differences in the burden of disease, injury, violence, or other opportunities to achieve optimal health, if you recall that definition from a previous slide. And so we measure health disparities with epidemiology measures. Epidemiology is the study of the distribution and determinants of health states, health outcomes. And so we use epi measures like birth rate or various mortality rates to help better quantify health disparities. And then that allows us to approach how we can address them. So again, that data-driven approach to moving the needle. We'll move along now, social justice. Which I mentioned a little bit earlier. So I really like this visual here. If we want justice, or if we want our tree to be strong, we need to make sure that everyone has the right foundation or the right soil. And you can see here all the things that go into the soil: housing, food, economic development, childhood, wages, all these different elements of the soil that help make a healthy tree or that healthy society. And now these social determinants of health, I think we can define them in a lot of different ways, but just broadly think about where we work, live, play, learn. These are the factors that influence your health. They're major drivers behind systemic public health issues. And they're not simple to solve, but because they relate to so many various factors. So you can think about things like socioeconomic status, transportation, housing, and access to these services, as well as things like discrimination. Again, where we work, live, play, learn. And so a classic example is thinking about poverty. It limits your access to healthy foods, and also socioeconomic status is linked to neighborhood safety. So you can see the interrelatedness of these various factors, these social determinants that do influence health. Just want to briefly mention this Rio political declaration. It was released by the World Health Organization in 2011. It has 5 main themes which reflect comprehensive public health approach to improving health and reducing disparities across populations. So I'm going to throw these up here, thinking about better governance, policy making, moving the health sector towards reducing inequities, global governance and collaboration, and monitoring progress and increasing accountability. And I put these up here not as a memorization activity, but a common theme that emerges here is that idea of community participation. And that's really crucial for policy making and implementation. And really, we all do have a role to play to ensure health equity. So again, this is more of that application and helping you to think of, okay, what are some ways, what are some activities in place, or themes in place to help us achieve that. I mentioned a little bit earlier the upstream and downstream. So medical care is typically kind of that downstream at the point of care, but I mean, this is a great example of a systems approach to looking at public health. And public health is really that upstream effort to address health disparities and inequities. And we'll take a look at some models that help us to better understand the various levels at which various levels of influence related to health behaviors and health outcomes. All right, so we have reviewed some foundational concepts of health equity, social determinants of health, health justice. Let's switch gears to discuss theory and how it can be applied. So public health programming is most effective when it addresses multiple systems level factors: individual, organizational, community. And this is where public health theories are really useful in informing public health programs and interventions. So to achieve the goal of reducing health disparities and to be effective, our programs and interventions also need to be effective. Public health theories are useful in informing these programs and interventions. So to answer the questions on here, what is theory? Theory is an interrelated set of concepts or constructs which are used to explain and predict phenomena. So really, sort of how we help to explain what we see around us. Why do we use it? We use theory to understand behaviors, explain behaviors, to understand where the best place to intervene might be, and then also to help shape that intervention and the selected methods used to change behavior. How do we use theory? We use it to develop inquiries or tools like surveys or instruments to test hypotheses around behaviors, and then to develop the most appropriate methods for intervention. So a theory is really a systematic way of understanding behaviors or situations. It helps us to better understand those disparities. Common public health or health behavior theories allow us to better understand the priority populations, perhaps differential risk for disease, and then opportunities for health promotion. And they're really integral in this field. While there's no like one size fits all theory that can be applied in any situation, there are several that stand out. We're going to go back to the social ecological model and start from there. And I just want to note that while we did go over some, definitions in the beginning part of this, while you're thinking about the theories, try to understand them conceptually. And then as you prepare for the exam, think about how you can apply them. So you will need to understand, the literal definitions of different elements of the theories, but then also be thinking about, different examples and how you can apply the theories to better understand examples and different behaviors and whatnot. And we'll go through some practice activities that'll allow us to do that. So we're going to start with the social ecological model. It's very commonly used. So traditionally, health promotion has targeted individual level factors, so that's your knowledge, skills, attitudes, beliefs for behavior change. But as ecological and systems thinking have become more prominent, programs and interventions have taken a broader approach to target other levels of influence. You have policy level, community level, organizational level factors. So the social ecological model, or SEM, was developed to help understand the very complex, multifaceted, and dynamic relationship between an individual and the environmental factors that influence health behaviors and health outcomes. This is a systems model with multiple bands of influence. You can see them here. They're all kind of nested in each other. So each one represents one of the 5 hierarchical levels of the model: individual, interpersonal, organizational, community, and then policy. And so as you go out, there is a greater sort of sphere of influence. So it allows researchers to better understand risk and protective factors, and then also to identify leverage points to address behavior change and health promotion. So just, as a quick example, we'll look at obesity. Think about the various levels of influence that can impact the outcome. Physical activity is influenced at the individual level by your self-efficacy, your perceived ability and to engage in certain behaviors, your self-confidence, by the social support of your friends and family at the interpersonal level. Then you also have workplaces and schools, which can play a role at the institutional, organizational levels. How about perceptions of crime and safety at the community level that may influence one's ability to exercise outside? And then finally, there are state, local, national policies related to nutrition and to healthy eating at the policy level. So we covered overall what the social ecological model is. Our conceptual understanding for this behavior is going to start at the individual level, and we're going to use individual level theories to explain and understand our investigation of this behavior. Then we'll move forward and look at some of those different colored bands and apply models, look at models that target other levels. So we'll start here at the individual level, Transtheoretical model, and the health belief model. All right. So the Transtheoretical model has 6 major constructs, the stages of change. So it posits that individuals move through these different stages of change, and changes in health behaviors require multiple actions and adaptations over time, depending on which stage of change the individual is located. So this model accounts for the individual's progression from not being ready, all the way to the long-term maintenance of a healthful behavior. So the notion of readiness to change or stage of change has been widely examined in the public health behavior research, and it can be used to explain or predict behavior changes. So while I do want to point out that while these are organized sort of like in a linear, straightforward fashion, that's for ease of presenting the material. Individuals may, move forward and then go back to different stages. They may get all the way to the end and then go through a relapse and recycle. So it is not meant to be 1 through 6 and you're done, but sort of this progression in multiple directions throughout to ultimately achieve that desired, positive, healthful behavior. So same sides here, but just, we have first the pre-contemplation. The individual has no intention of taking action now or in the foreseeable future, and we'll think of that as like within the next 6 months. This is characterized by generally the unawareness of that behavior, maybe like the problematic nature of it or the unhealthy nature or the negative consequences of it. If you move forward into the contemplation, one of the things I love about this is I think the little stick figures do a really good job of like showing you kind of where the person is. So now they're on the fence. They do intend to engage in the healthy behavior at some point in the foreseeable future in the next 6 months. And now there's that recognition of this behavior and, of its consequences of what the behavior really means. In the third phase, you have determination, preparation. Individual is ready to act, right? You see, yes, let's go. I'm motivated. They plan to really engage with this in this behavior within the next 30 days. And this is characterized by taking those small steps. You can see the person's gearing up towards that behavior change. Next is action, where you have the individual has recently changed their behavior, within the last 6 months, they're actively engaging in it and they plan to continue engaging in the behavior. They may exhibit this by modifying the original behavior or by acquiring new, healthier behaviors. In maintenance, the individual has sustained their behavior change for more than 6 months. This is characterized by an intent to maintain the behavior change. And the focus now is on continuing that on the maintenance and to prevent going into the earlier stages that we discussed. So, the individual can move towards a relapse or recycle. And, we've all experienced this as we're trying to adopt new behaviors or, implement something new, or you may experience a situation, a setback, if you will, and you may go back into previous behaviors, but then this model, like I said, it's not just linear. It allows you to sort of move through the different stages. And so the goal would be to sort of be in that maintenance phase, but it's very possible that the individual may need to recycle and go through the different behaviors. They may also sort of hit a termination where they're deciding not to adopt the behavior long term. And I think like a useful sort of frame or an example is, one example we can think of is among people who are at high risk for diabetes. So, or to improve the success of health counseling. So you can think about those as examples of how an individual, and then you can think of examples of how an individual may move through those different behaviors. So when we talk about people being in the stages of change, and so now you see that those are like it's the bar across the top of the slide. There are also various processes of change that can help people move forward. So, they may think about the pro cons of, the moving forward, the pros helping them to continue moving forward, the cons being those sort of barriers to moving forward. What's their self-efficacy? What's the confidence that one has in their self, that they have the skills and the capabilities to carry out the behavior, in multiple settings and over time, despite these barriers. And self-efficacy is also like a theory in its own. It's a critical construct in multiple theories. So we're going to discuss it sort of as it pertains to other theories versus by itself. All right, so some time now to walk through an example. So I would like you to throw in the chat, an example of a health behavior, and then we'll look at one and talk about how it applies to each stage of the transtheoretical model. So pull up the chat and just share in some, we'll give it a couple Okay. All right, so I think smoking is coming up here, smoking, tobacco. I see a lot of really good examples also related to, physical activity, exercise, weight loss, healthful eating, um, substance use. All right, so we will use smoking as an example, just I saw that one pop through. Feel free also to, in an offline exercise, pick any of these other ones or an example of your own and then walk through the different stages and think about how they can, how you can apply each stage. So let's go back to, okay. So now in the chat, I don't quite know what everyone can see, but hopefully everyone can look at their own chat and let's now, so using smoking as an example of the sort of initial health behavior, walk through sort of different steps that an individual can take to modify that health behavior. So what would be sort of like a pre-contemplation example of smoking in the context of the trans-theoretical model? Yeah, great. So, right, people are saying, I don't have a problem. What's wrong with this? This isn't an issue. I've always done it. It's normal. So, right, you may be influenced by some social norms here. So this sort of, well, it's around me. Other people are doing it. I've always done it. I'm not harming myself. So, right, this is characterized by they're not taking action. They may not even be aware of the behavior or of its consequences. Let's move forward now. So if the individual has moved from pre-contemplation to contemplation, what may they be thinking or how can we sort of exemplify smoking in the context here? Again, in the contemplation phase now. Yeah, maybe I'll do it. Okay, a recognition. I don't know that this is good for me, right? I'm getting older. Maybe I should quit. I had a health scare. I want to be around with my family, right? So this sort of like, again, this visual, I'm on the fence. I've recognized that this behavior may be problematic. It may have outcomes that I don't want to have. Seeing some symptoms, yeah. These are really great, and thank you, everyone. I know I'm not able to like address every single one that comes in the chat, but I think you all are really understanding this. We're going to move forward now into the determination, the preparation. So what would this look like for someone who's smoking? They've contemplated, okay, maybe I want to quit or reduce my smoking. Thinking about it, I'm seeing some indications. What would determination and preparation be? What resources are there? I'm going to make an appointment, talk to my doctor, support. Yeah. Recognizing, what others have gone through. Cutting back. So see, and you can even see sort of like the nature of what you all are saying. There's that, again, that, yes, let's go. I'm motivated. They're determined and ready to act. And so now if an individual has moved from determination preparation, they're into action. They're wanting to, engage in smoking cessation. What does the action look like for this example? Yep, cessation medications, attending meetings, cessation class. Truly, yeah, quitting cold turkey. This may look different, right, depending on who's engaging in it. So even when we're talking about examples of the behaviors, it's not a prescriptive one size fits all. You can see here there are dozens and dozens of ways that we can exemplify the sort of each stage in the trans-theoretical model. Make a plan, know your triggers. Really great. Seeking support. And so we've seen support, I think, like in every single stage of the transtheoretical model, and that kind of goes back to that social ecological model of the sphere of influence. Getting rid of tobacco, right? So removing those cues that may be influencing behavior. Okay, so now the individual, yes, let's go, we're doing it. What would the maintenance phase of smoking cessation look like? Getting support one day at a time, stick to your plan, avoid triggers. So again, we're seeing support here, trying to remove those cues that may be leading the individual into the behavior that they don't want to engage in. Sort of those, and continuing with programs, seeking support, mental models of how we engage with ourselves. Yep. Replacing it, yeah, so sort of substituting or modifying a behavior by including another behavior to maybe take its place. And now let's say this individual has sort of gone back in to, we'll call it, recycle. What made this now look like if they've sort of taken that path in their smoking cessation journey? What would a relapse or a recycle look like? Yep, so now you're starting to smoke again, yeah. And so in this buying tobacco just in case, right? I'm doing it with people, with my friends. So in this case, I like, the relapse recycle is fully back to the beginning. And I apologize, I wasn't very clear with that, but again, you can move forward. You can move from stage to stage in any direction. It doesn't need to be, 0 to 100. Thank you all. These are like, we could, spend so much time going through different examples, but I think you seem to really grasp what I was trying to get at with the stages of the transtheoretical model. And again, I encourage you in an offline activity if you want to work through your own health behaviors and think about how an individual may look at each stage. So we'll keep going. All right. So now, second theory within the individual level of the social ecological model, we have the health belief model. So behavior change to succeed in the health belief model, people must feel threatened by the current behavioral pattern. So there's this perceived susceptibility that's like, how likely am I to get this disease? Disease could also be health outcome. It's not quite as, like, okay, this actual disease, but the outcome of interest. And also, if I do have the disease or the outcome, what's the severity of it? How's it going to impact me? So they have to feel threatened by the current state, the behavioral pattern. And then they have to believe that the change will result in a valued outcome, so perceived benefits minus the perceived barriers. So what's the acceptable cost given the benefits that they should receive? And they also have to feel competent, again, that self-efficacy, that they can overcome any perceived barriers in taking action. We're not going to go through an activity here of the different elements of the health belief model, but again, I encourage you to walk through that as you prepare for the CPH exam. You can find tons and tons of examples online. So I'll just leave these up here. Again, it's very definitional of what the health belief model is. And since you will have access to the recording, you can go through and reference this at any time. So again, those key concepts: perceived susceptibility and severity, and then thinking about the benefits minus the costs. What are your cues to action? What helps activate readiness? And then what's the self-efficacy, confidence in your ability to take action? All right, we've made it through the individual level. We're going to step forward now to the interpersonal level. And we'll cover the theory of planned behavior and the social cognitive theory. Theory of planned behavior grew out of the theory of reasoned action. It was proposed in the 1980s to explain and predict how a behavior is formed. So really critical to this model is the behavioral intent and the belief that these intentions are influenced by the likelihood that the specific behavior will result in the expected outcome. There's also a subjective evaluation of the risks and benefits of these outcomes. So this theory posits that behavioral achievement depends on both the intention, so what is your motivation, as well as your behavioral control over that. And it's comprised of 6 constructs, we'll show them on the next slide, representing the individual's control over the behavior. All right, so we'll sort of start with the intention and then work backwards to the different elements. So behavioral intention is really what factors, motivational factors influence a behavior. Okay, so what's going in, what factors are ultimately influencing the behavior? And the stronger the intention to perform the behavior, the more likely it is that the individual is going to engage in the behavior. So you can have things like the attitude towards the behavior. So what are beliefs that go into that? Evaluation of behavioral outcomes. The belief that the behavior is going to make a positive or a negative contribution to that individual's life. You know, the subjective norm. So these are factors surrounding the individual, like their social network, their cultural norms, group beliefs, and the individual's belief as to whether others are going to approve or disapprove of their behavior. So there's a lot to be said about those social norms. What's considered normative for a group that can influence your behavioral intention. And then you have perceived behavioral control. These are factors that act as barriers or facilitators to the behavior. And so you can think about, perceived behavioral control is how easy or hard it is to adopt the behavior. And that includes the power, which is perceived factors that act as barriers or facilitators. So again, you have attitude towards the behavior, subjective norms, kind of what's going on around me, and perceived behavioral control, all influencing the intention, which influences the likelihood of engaging in the behavior. All right, we're going to move next into social cognitive theory. I like this one I like the visual here on the right-hand side. Social cognitive theory suggests that learning occurs in a social context, and it's a reciprocal and dynamic interaction between the person, I don't know if you can see my mouse, the person, the environment, and the behavior. So it really emphasizes the social influence and the internal and external social reinforcement that we get. So unlike other health promotion theories, and again, this doesn't mean that one is good and one is bad, but just different context, social cognitive theory focuses on the maintenance of a behavior rather than the initiation. Although we do see that to a certain extent, like with the Transtheoretical model. So it's based on the belief that people learn through their own experiences, but not just through their own experiences, also by observing what's going on around them. So some key concepts here, we have reciprocal determinism. Again, that's that dynamic and reciprocal interaction of the person, the behavior, and the environment. A change in one is going to mean a change in the other. So it's sort of like this waxing and waning, right? If you're seeing a change here, you're going to have a change in the other areas as well. This is a key concept. And it really, the influence of the person, the behavior, and the environment really says that this helps to facilitate self-regulation and goal-directed behavior. You have behavioral capability, and that's an individual's ability to perform a behavior through the essential knowledge and skills that they have. There's also observational learning, so it's one's ability to witness and to observe a behavior that's conducted by others, and then to model or reproduce those actions. There are also reinforcements. So what are the internal and external responses to a behavior that affect the likelihood of continuing or discontinuing the behavior? These reinforcements can be positive or negative. What expectations do you have? Anticipated consequences of the behavior, self-efficacy, we're hearing that term again, an individual's confidence in their ability to perform that behavior. And then self-regulation. This is a uniquely human element. We have the capacity to self-regulate or to set goals. So this is the process by which you're engaging in self-directed behavior. People learn by observing the behavior of others, and how those behaviors are reinforced or appear to be reinforced. And so this is that really reciprocal sort of interaction. And the observational learning is a component of vicarious reinforcement. So the process by which someone is learning to interpret stimuli and anticipate reinforcement, and then also by modeling. People behave so that others are following their examples. All right. So now in the chat, we will just throw an example of another health behavior, and then we'll walk through some different elements of maybe, personal, environmental, and behavioral factors. Oh, so let's go back, give everyone a little bit of time. All right, so we'll see what examples come up here, and then we'll go through. All right, so I'm seeing overeating and healthy eating. So let's look at, thank you to everyone who's contributed examples. Let's look at engaging in healthful eating, or maybe moving from unhealthier eating habits to healthier eating habits, and think about some ways that the person, the environment, and the behavior can all interact. So this is a little more applied than just like the level, the stages of Transtheoretical, but what are some sort of reciprocal and dynamic elements that may relate to your eating habits? How the rest of the family eats, cultural habits, healthy eating, family, stress, what's in your refrigerator, what access you have, social media, culture, money. Yeah. So for example, you can think of your personal factors, your values, and your beliefs. What are your own beliefs surrounded to food? What to you constitutes, eating well? What's your self-efficacy? How do you think, what is your confidence in your ability to be able to engage in healthy eating? And I see example of body image, right? So what sort of that intrinsic, that internal, those personal factors? And then we saw some examples of environmental factors. So in your social network, what is quite literally around you? What are your friends and family eating? What access to foods do you have? What policies and procedures are in place to support or that don't support healthy eating? And then your behavior, what are your actions and choices? What have you observed around you that may influence your decision, your willingness, your ability to engage in that healthy eating? Yeah, these are all really great examples here. We could go through, I saw also like vaccinations, mask wearing. I think those are really relevant coming out of, the pandemic, the acute phase of the pandemic. So again, encourage you to sit through and just like work through these. Like I said, I try not to focus on the definition, but really on like the concept that these models are trying to embody, and how we can move through them with different health behaviors. So we're going to move forward. I do have one sort of last level of the social ecological model to cover. So we talked about individual and interpersonal. We are moving now to community. We're not going to discuss any models targeted at the organizational or policy. And we're going to focus on community, Roger's diffusion of innovations. And thank you everyone for your willingness to engage in the chat. I just want to keep us moving forward. Yep. So diffusion of innovation, I think this is a fun one. It's just a cool way of thinking about it, because there are a lot of sort of applications that we can make. So behavior changes as innovations are adopted. So it's sort of like moving through this adoption process. There are lots of different constructs. So I'm going to go ahead and throw everything up on the screen. Yep, we have everything up here. And then we'll kind of work through it. So at the bottom here are the constructs. So you have innovation. What is the new idea, the new product, process, whatever it is that you're trying to implement? What are their communication channels? Those are the methods to make the innovation known to this social system. Time, the time it takes for the the innovation decision process to occur, but then also the time for the rate of the adoption. The social system is the group into which the new innovation is introduced. And then what are the attributes of the innovation? Like, is it, new technology? Is it promoting a new behavior? Is it a new process for how things are done? And so we talked about these constructs down here, and really one way to neatly, succinctly sort of summarize them. So this diffusion of innovation, it's the process by which the innovation is communicated through various channels over time to the members of the social system. And those behavioral changes then occur as the innovations are adopted. But we know that not everyone is going to adopt all at once. So there are different characteristics of different individuals that sort of make up this way of adoption. And it follows a typical bell curve. So most people, about 70%, are going to fall into the early or late majority. Okay, so that's over 2/3 of your group is going to fall into one of these two categories. The other 30 or so percent is going to be on either end of the bell curve. So you have, you have innovators. Those are, they are the first to try it. They fully embrace and adopt the new innovation. Early adopters, and these represent like the smallest majority of people. Then you have early adopters. So these are the folks that say, all right, I want to embrace change. They're typically leaders who are aware of the need for a change, and they're comfortable with those new ideas. So they're still in the early adoption process. Then you have the early majority, which is a full 1/3 of your group. They adopt new ideas really quite simply before the majority. So they're on the earlier end of adoption. And then they're followed by this other 1/3, the late majority. They're skeptical of change. This does represent, 1/3 of people, but they're going to adopt it after like these other 50% of people have adopted it. And then in the final chunk, about 16%, you have the laggards. They're very skeptical of change, and they're only going to adopt, if at all, at the very end. So I think like a classic example, not necessarily health related, is like adoption of a new technology. So, when we have this new like gadget that comes out, or this new sort of like software, what's the rate of adoption? What's the group that it's targeted to? How is it communicated? What is the sort of like group perception of it? And then you'll have folks that fit into these different elements within the bell curve that'll adopt or not at various points in time. So just a visual explanation of the definitions that I threw up there. And you want to think about some elements, and this is just to get you thinking. The advantage, is it better than it was before? Like if it's replacing a process or a technology or a product. The compatibility, is it fit for the audience? Complexity, is it easy to use? Trialability, are you able to sort of test it out before making that final decision to adopt? And observability, once we've adopted it, are the results easily visible and measurable? So these are all considerations that may come into play as people are adopting it. All right, so we're going to tie it all together now. We have reviewed different definitions related to health equity and social justice. And then we covered various health theories, and we learned that different theories, using the social ecological model, we've looked at different theories based at the individual, interpersonal, and community levels of the social ecological model. And while we didn't consider multiple at once, I also addressed how combinations of interventions targeted at different groups at multiple levels can be used to positively impact health behaviors and health outcomes. All right, so the remainder of the time is going to be devoted now to Q&A. Ashley, should we go through what's in the chat, like the questions and answers first, and then we'll move to the practice
Yeah,
questions?
that's a great idea.
Okay. Yep. All right.
All right, so the first one is to tackle the group or community behavior of smoking. How do we identify the group that is ready to adopt the new behavior?
Sorry, I had to unmute myself. It's a really great question. So this was not really covered within the scope of my presentation, but a big part of thinking of, preparing for the CPH exam is thinking about those sort of community engagements and partnerships. And so to help contextualize it, when you're thinking about implementing like a behavioral change, modifying behaviors, there are going to be community leaders who are involved with people. And so you'll do this sort of stakeholder identification process, and it'll be a sort of community engaged, community informed activity, and then leaders can help to identify sort of groups or individuals that may be motivated, that may want to engage in these changes. So it's I think the one downside to sort of focusing on one topic is that it kind of puts it in a bubble, but think about these other sort of elements of your public health training and coursework. I hope that answered the question.
Yeah. Someone just asked if you could go back to the last slide so they could see it.
This one?
Yeah, so I'll have the next question and then we'll leave that up for a second. But the next question is, does this have to be an actual social group, or can it be influenced by virtual groups online?
Oh, that's a great question. And certainly now more than ever, we're seeing the role of like virtual platforms. No, it can be virtual as well. We are in a very connected world. It does not have to be literally who's next to you, but everyone's definition of community can look, or who you consider to be part of your community could look a little different. We're not constrained by geography or by literal proximity. And certainly we do see the value of online platforms in helping to bring people together who may want to, engage in certain behaviors or whatnot. Great question.
All right. The next question is, does the Transtheoretical model mode apply to individuals with addiction or mental health issues, since those are so cyclical behaviors?
Yeah, I think you can certainly apply it in that context. Let me flip back. I'll go to this slide, but just so we can look at it all as a group. Yeah, and so that was thank you for that question, and that's a good example. Like I said, I know this is presented as like 1 through 6, but this can be applied to like any sort of behavior, and you could even extend it and say, not just a help behavior, but like, how you engage in any behavior in your life. And I think that's a great example because it does sort of contextualize that change is not just, next step, next step, next step. There can be fluidity throughout the different stages, depending on where the individual is.
Okay, then the next question is, what is the difference between the Transtheoretical and I can't remember what the HBM stands for.
Oh, the health belief model.
Yeah. Mm-hmm.
Yeah, so there are different ways of thinking about the individual level of the social ecological model. They provide you with sort of different ways of thinking about how that individual level. Like I said, this concept of self-efficacy appears, it's like bread and butter in health behavior theories. So it's less of a focus on how they differ in literal definitions, and it's more a way of just sort of how you can contextualize behaviors and what goes into those sort of activities related to behavioral change.
So the next one, how does the social cognitive theory differ from the social ecological model? Both seem to suggest that our behavior is a product of individual, interpersonal, and environment factors.
Yeah, and I think, let's flip forward to that. That's a really great, yeah. A similar sort of concept that these are just ways of thinking about health behaviors and how we can promote healthy behaviors. And I think, yeah, I did mention that this really like focuses on the long-term maintenance. And so it's that broader systems level thinking. So social cognitive theory is, because again, now we're at the interpersonal, and so that kind of inherently gets at the like dynamic interactions that we have with those around us. So I think the social cognitive theory just sort of hones in on the interpersonal level, but you can certainly see the role that different right, because like it has the environment, and so you could think about, okay, environment's not just interpersonal but these other elements. So these are just lenses for thinking about sort of theoretical frameworks.
All right, the next question has to do with how this connects to social justice. So can you explain the connection
Yes.
between the theories and social justice?
Yeah, thank you. That's a great question. So okay, so we talked about the example of the tree, right? You want good soil to make a strong and healthy tree. Social justice is that everyone deserves rights and opportunities to be healthy, and rights and opportunities including the right to be healthy, the right to good health. And so these frameworks help us to consider ways in which individuals can engage in healthy behaviors or engage in new behaviors that they want to adopt. So when, and again, here's that concept of self-efficacy, you know, belief in your ability to be able to engage in a certain behavior. So these models that we've discussed sort of allow us to kind of look at the sausage making, if you will, right, of what goes into health behaviors, what goes into individuals' activities, which then may help us ultimately achieve that goal of health for all.
One question in the chat that I see is, can you skip some steps in these models?
Can you skip steps in the models? Is that the question?
Yeah.
Oh, I these models are broken out. I just landed on here. We can go back to anyone. Let's look at an example. So this is broken out very neatly as sort of like in part of the learning experience. I think it's not every activity is going to fall like discreetly into, oh yes, I am only in the pre-contemplation phase, and you know, this is again a way of thinking about them. How the individual approaches it, it's going to be a little bit different depending on the situation, what the behavior is, who the individual is, the context in which the change is occurring. So I wouldn't say it's like about skipping or hitting every one, but sort of again the overall framework of how is the model explaining how health behaviors are implemented and how change is executed.
Okay. Okay. And then I think the last question here is, how do the social determinants impact these two models? And I'm not sure which models they're referring to. It says not everyone has the same, and they do have different beliefs. How do we adapt these models to learn behaviors?
Sorry, can you repeat the question? Are we talking about the health belief and transtheoretical?
Denise, could you put in the chat which ones you're talking about? And then here, while we're waiting, the question came in, can you combine some of these models? Is that an effective approach?
Again, I think it's not, these help us to think about ways that individuals can engage in change. So you may want to sort of think about different elements, and certainly, we looked at the social ecological model. And sorry, right. So we talked about theories at different levels. And so, yeah, you can certainly employ one or the other or multiple at different levels to really, or even multiple within the same level to help address that change. So again, more of the theoretical framework and then how it is applied is going to be contextually dependent. And sorry, should we go back now to that question? I'm not sure if we were able to get
no,
more
I didn't get an
clarity.
answer, so I'm sorry.
Okay.
Let's skip that, and if we
Yeah,
get
if
it,
you
we can jump to
Sure.
that later. We can start. We have quite a few practice questions for this one, so
Yeah, should we move?
Yeah, some great
Yeah.
questions to go through.
Oh, okay. All right, do I move forward now, Ashley, to the next one and you'll put the poll EV up?
Yep, so if you just
Okay.
put up the first question, I will start the poll for question number 1. So everyone should see it. And I'm going to leave it open for about 45 seconds. That's about 30 more seconds from now. All right, a few more seconds. Okay. So we have 64% that said poverty.
Okay, great. Yep, so that is the correct answer. So think about poverty in the context of the social determinants of health. So this is sort of an application of your understanding of the social determinants of health. Researchers have identified that socioeconomic status is really a fundamental cause in observed inequalities. And so the sort of the differentiating factor of why poverty was the best answer is that what occurs around you, the context, the situation is often more meaningful than genetics, and really so those social factors have great influence on health. So that's what this question was seeking to address.
Okay.
All right.
Okay. Next one. All right. So this one we have 93% that said determinants of health.
Okay, great. Yep. So these factors that contribute to the health of individuals, groups, communities are the social determinants of health. That is pretty much a recall question. I do have a couple of those on here. I think health behavior factors would probably be another top contender, but really social determinants of health or determinants of health are those factors around us that influence our health status and health outcomes.
So for the
So
first question, we have a question of why wasn't genetics the answer?
That is a really good question. So genetics certainly does influence your literally who you are and what may happen to you. But we have seen increasingly that the sort of the context, the environment in which those genetics play out it has just so much importance on health status. And I think this is more also thinking about it from like that societal level of what factors can be used as predictors of what the health outcomes are. So it's more of that sort of like broader level than thinking individual level.
Yeah, it says right here, somebody said too many factors due to poverty is greater than factors of genetics.
Yeah, right. So it's thinking about the sort of context. Yeah.
Mhm. Okay. All right,
Thanks.
ready for number 3?
Okay.
Okay. So this one, it looks like we have 87% said social determinants.
Yep, great job. That's very similar to the last question. What are the social determinants of health? Right, they impact our overall health and our quality of life. And so those income, stress, education, right? We can also think about housing, access to food, safe transportation. Those are all social determinants of health. The others are sort of just distractors. They kind of get at what we're trying to discuss here, but they don't fully hit the mark. Ah, yeah, okay. Okay, next one.
All right, ready? 4. Sorry, you know what? It's not launching here. Let me see.
Yeah.
Yeah, I'm sorry, everyone. I don't know why it didn't launch. Let me start it over again. We had this problem last time, and then
Oh,
it just
gosh.
wouldn't launch. Right. Yeah, how about we put the answers in the chat then for this one? So we've got 2, B, so the second one, B, D. Getting a lot of D's and B. A lot of, I think the majority is B.
Yes. And those are both really great answers. The correct answer is B or 2, and I'm realizing now that yeah, it's very ambiguous as to whether these are 1, 2, 3, 4, A, B, C, and D. Anyway, yeah, okay. So the correct answer here is the second one. And so when you're thinking about social justice, again, that definition of the distribution of wealth, privileges, opportunities. So a socially just health system would provide access to care to all individuals. So that's why ability to pay would not be a factor in whether you're receiving that care, because in a socially just, society, all would have the ability to obtain their health. And I even had, a note here, individuals should be involved in determining resource allocation, but that's not fully what the, sort of intent of social justice captures, which is why that second choice, again, it's that single best answer. It fully captures what that concept addresses. All right, so it works.
Let's see if I can get this one to work. Does everyone, okay. Does everyone see it?
Yep.
Okay. Okay, about 5 more seconds. Okay, we have a bit of a split on this one. We've got 45% said structural racism. However, institutional racism has 31% and social epidemiology has 17%. So there's a big mix. However, social or structural racism is their top.
Yes, and great. It's nice to see sort of an array of responses so we can walk through. Sorry, for some of these I have more explanations than the others, so I just want to make sure that okay. So the correct answer is institutional racism. Yeah, so you know, we had 31% of respondents answer that. So this occurs within and between institutions. I will leave this blurb up here for a second to let you read it. We did briefly cover sort of the different forms that racism can take at the beginning of this slide. And so this is thinking about, again, like the different institutions that come into play and how those can then reinforce those unfair and inequitable opportunities. Structural racism is not the right answer here, though I do see why folks have selected that as the choice. Let me go back to my notes just so that I can make sure that I think there's a little nuance in the answer to this question. So I can see why structural racism would have had a lot of responses as well. And happy to chat offline, although this is not my area, but also I know some people did answer causative factors. These are just really more broadly the risk factors that cause or contribute to health outcomes. So it's not incorrect to think about like factors that do lead to these outcomes. Yes, those are causative factors, but doesn't fully capture the intent of this question. So we will move forward. Okay.
I think for that last one is important to understand the definitions and the difference between those definitions.
Yeah.
Mm-hmm. Five more seconds. Okay, this one, we have 78% that said including diverse constituencies in the decision-making.
Yep. So, which of the following practices enhances equity in population? Oh, and yep, 78% did select the best answer for this question. So it's important to frame questions that need evidence and then select the most appropriate type of evidence. So having diverse constituencies at the table during that decision making, it helps to acknowledge different viewpoints, right? So we're gathering that evidence, incorporating different viewpoints that will that will enhance equity and health policy decisions. And again, that root of that equity is that justness and that fairness. So it is an equitable practice to include all different types of people, giving, everyone that right to achieve that optimal health. Allocating resources simply on population size, it may not target resources to populations that need it. And collecting health-related data is certainly really important, but having data alone without like the context, having a diversity of stakeholders weigh in, doesn't fully embrace the idea of enhancing equity while making health decisions. So that's why, we had 3/4 of people who answered correctly, include those diverse constituencies, that justness and fairness when you're making health policy decisions that are going to impact everyone in that community. Great job, everyone.
Next one. All right, I'm going to close the poll. Okay, so this one we have 79% said health disparity.
So, great job, everyone. It is a health disparity. This is an application of the definition. And I think this is a pretty apt example of sort of how you may be asked to understand and then apply these concepts, in the context of the CPH exam. So you're seeing, okay, lower incidence in this group, but they have a higher mortality rate. That's a health disparity, which is, again, definition-based difference in the health status between two groups. So this question is designed to help you think about what each of these, different options describes, and then which best answers the question. So for example, harm reduction would describe an action taken to reduce the health disparity. So health disparity is sort of like that underpinning right answer, because any other option here would honestly be based off of the fact that you identified the health disparity. So sort of application of the definition.
All right, next one. All right, this one, we have a pretty clear response that we've got health literacy is 98% of the responses.
Okay, yeah, 98%. Yes, that is correct. I know we didn't specifically address definitions of these, but sort of using the context here, yeah. So, your sort of understanding of your ability to first get and then understand, health related information is health literacy. Medical informatics, that's like related but not the same. That's sort of the IT based innovations. It's more application based, related to healthcare services delivery. Health education, so that's promoting the sort of spread of information related to health promotion. And numeracy, ability to understand and work with numbers. So 98% of you, correctly answered health literacy. You guys are doing a really great job here.
Couple more seconds. Okay, this one we've got 88% say competence.
Yep, so let's go through. Cultural competence, cultural competence is the correct response here. That's the ability of the professional to be able to deliver services that really meet the needs of the group, and that's depending on, you know, what their social needs are, cultural, linguistic, etc. Cultural competence is really a big part of this health equity and social justice module. I don't have any other context here, but this is sort of you know, so it is the single best answer. Cultural competence, really meeting the different needs of the constituents, you know, that you are working with.
Right, so this one we have 76% said C, a construct to explain the nature of phenomena. But we also had 22% that picked B, a tested set of hypotheses listed in order of importance.
Yeah, so this was also definition recall from earlier. As I sort of explained the different theory or introduce the different theories that we're going to talk about. Theories are a way of helping understand what we observe in the world. Construct to understand the nature of phenomena. That's why that's the best answer. I certainly understand how folks would pick the second choice. That actually refers to hypothesis testing, which is not quite what theory fully captures. That's related more to sort of testing what you believe to be going on, but the theories help to just explain what you are observing. So it's more, again, putting that context and enhancing the awareness and understanding of what you're observing. So that's a recall definition question. And the other two are.
We have a question in the chat that says, is a construct a helpful clue for the definition of theory?
I think construct is commonly used when defining theory. I do not think it is needed. It is necessary to define theory. But yeah, I think you can think of the theory as sort of like the way by which you explain something. So yes, construct is a helpful clue in this set of question and answer choices. Good to proceed?
Yep. Okay, this one we've got 80% say the socio-ecological model.
Yep. So that is the correct answer. This is sort of definition of what we discussed earlier. Social ecological model looks at all that sort of hierarchical, right, from the individual all the way up to like the policy and the political context. It's an interrelated set of factors that influence health. it's a systems approach to understanding health. I don't quite remember what like the next top choice was, but transtheoretical model, that is at the individual level of the social ecological model, moving through those 6 stages of change. So maybe sort of hits some elements of what this question asks, but again, doesn't refer to the combination of all those interrelated factors. Social learning models, also social cognitive theory that we saw was at the interpersonal level, you know, the integration. So sort of maybe a little bit of a distractor. And theory of reasoned action or theory of planned behavior thinks about how and why behavior is formed. So again, these are all sort of like at different levels of the social ecological model, but that is the single best choice because it refers to that interrelated set of factors.
Okay. Right. Okay. So this one we have a split, but however, I noticed I made a typo when I typed the poll, which may explain the split. So we have a split between informal social networks and personal knowledge of skills. And so the poll said interpersonal. And so the question,
Wait, sorry, the poll said what?
Interpersonal factors, which may explain, yeah, why we have the split instead.
Yeah. Oh, wait, and yeah, did you said it was inter?
Yeah. So
Yeah, right. So intra, yeah. So the individual behavior, that I have it covered. Yeah, okay, so intrapersonal, so like within the person, that refers to like the individual's characteristics, like their knowledge, attitudes, but you know, skills and whatnot. So that is the best answer because you're focusing at the individual level. So we can, I'll just leave this up here so everyone has the correct wording, but yeah, I think that may have explained some of the confusion.
Okay.
All right, so
Okay, so this one, we have a bit of a split again. Which of the following constructs from health belief model? So 47% said decision balance, but then we have cues of action as 20% and barrier at 19.
okay. Yeah, So let's move forward. Okay. This is just a sort of recall of thank you for showing. Yep. Yeah. So, right. Most people did answer decisional balance. The majority of responses were for that 47%. This is just kind of recall of how that model is oriented. I know we didn't spend a ton of time on it, so I would encourage you to go back to it, but we did spend time talking about susceptibility, right? So like sort of, am I even, sort of, might this outcome happen to me? Like, what's my chance of this occurring? The barriers, we talked about what are the positives, what are the benefits versus the cost, those barriers. And then cues to action would be sort of those cues that it would encourage the individual to then engage in that behavior to make that change. And so decisional balance was just not something that was talked about in that model. So I encourage you to go back and look at that again.
Okay, this one. About 63% said screenings are important to stay healthy.
Yes, and that is the correct answer. So I know this is a lot of text, but what I want to focus on is how the health belief model really highlights that it's an individual's belief about their susceptibility, and then again that sort of benefits versus barrier. So that influence their likelihood to participate. So if you believe that there's that desirable outcome of staying healthy, that will influence your willingness to participate in that healthful behavior. And you know, the majority of people did respond to that. So good job applying the concepts of sort of this belief about your susceptibility and the benefits versus the barriers to what that action might look like in real life.
Okay. Ten more seconds. Okay, here it is.
Yep, so this is sort of a application of understanding the different constructs of this model. I know we didn't go into specifics of the definition, but right, by process of elimination, counter conditioning is the only one that really gets at substituting those healthy behaviors in place of the unhealthy ones. So you are sort of countering what the environment is, replacing it so that you can continue to engage in that behavior. consciousness raising is really what brings the individual's awareness of, the need for change or the benefits of the change. So it's not really related to the actual substitution. Reinforcement management is where you would sort of reward the positive behavior and simultaneously not to reward the behavior you don't want to engage in. So it doesn't refer to the actual substitution. And stimulus control is more about re-engineering the environment. So with that in mind, counter conditioning is the best response.
Right. Yeah, 72% with stimulus control.
Okay. Yep, great job, everyone. So honestly, we sort of talked about the answer to this question in the last one. So it's a good application of sort of the different elements of these theories. Removing the stimulus to foster an environment where the individual's not, the word here is triggered, where they're not sort of cued to participate in the behavior that you're trying not to engage in. So sort of recall, definition, and then application of and elimination of ones that don't really meet what this question is trying to ask. Good job.
Okay, so this one, we have 60% that say, sorry, I keep forgetting to share. 60% say self-efficacy and 31% say perceived susceptibility.
Yeah, and I can see why there would be that split in the responses. The majority did answer correctly. So I think the key in this is it's the confidence that they can successfully change. Self-efficacy is that confidence in your ability to be able to initiate or implement that behavior. So it's situation specific. A person can be confident in some circumstances and not others, but when you're thinking about, your confidence that you can change, that refers to your self-efficacy. Perceived susceptibility is referring to your understanding of how likely you are to get that disease or condition or whatever the outcome is. So it's not your confidence that you can change, it's sort of your perception of what the outcome is, how likely it is. And then perceived severity is how impactful you would consider that outcome to be. And I don't think there were a lot of people who responded to severity or cues to action, but those are just the tools that helped activate you to get ready. So self-efficacy, again, the trigger, sort of the tip-off word there would be confidence that they can change.
little bit of a split here too. So we've got 40% say perceived behavioral control, and then 35% say behavioral intentions.
Yep. So perceived behavioral control is the correct answer here. I don't actually know how much we went into this specific the nuances between the two. So I think maybe this question does not most accurately capture what I covered in the slides, but yeah, they both focus on the relationship between, behavior, beliefs, attitudes, and intentions, but the theory of planned behavior, which we did cover, adds the concept of the control, which we did discuss. So I apologize if that was not the most apt question for this, but a lot of people did understand the difference. So.
All right, 19. Okay, a little bit of a split here. I'll share this.
Okay, yep, we do have a split here, so let's go forward. Okay, so the correct answer is the behavioral intention. So this is again similar to that theory of planned behavior. So your intention is the most important driver of the behavior. That's the likelihood of performing it. Your behavioral intention has a lot of factors that go into it. If you recall, there was like the chart with then the different arrows sort of leading into like the norms and the power, and then you have the behavioral intention, which impacts behavior. The outcome expectations are related to social cognitive theory. The benefits are related to health belief model, and then stages of change are part of the Transtheoretical model. So those are more distractors based on sort of the model they belong to, but behavioral intention is really key to the theory of reasoned action, similar to theory of planned behavior.
Okay, next ones. We only have 3 more after this one, so not too many more.
Yeah.
Alexa, I just sent you a note in the chat too. Ten more seconds. All right, so let's go through this one. So 58% did say cognitive or social cognitive theory, but we have some other ones that have some higher percentages too.
Yep. Yeah, we'll go through. This is actually from the theory of planned behavior. Again, similar to the theory of reasoned action. So, normative beliefs are related to sort of like those subjective group norms. And so I can see why people would answer social cognitive theory, because we talked about sort of that reciprocal determinism between person, environment, and behavior. But when we're thinking about the normative beliefs, that's like the subjective sort of norms. What are other people doing? What will my peers think? And so on. And so that was a construct from the theory of planned behavior. Oh, okay, yeah, that was That's the definition that I have there. So it's, I know some of these theories may be newer. We haven't had a lot of time to sit with them, but really, I'll talk at the end a little bit about, some suggestions for how to review these, but this is where the construct originates.
I launch the next one.
Okay. Yeah.
I'm gonna give you about 10 more seconds on this one. Okay, this one. Let's take a look.
Yes, quite the spread for this one. So the correct answer is reciprocal determinism. That was a recall definition. And I see how some of these others are like distractors, especially tridirectional dependence. The reciprocal determinism, again, that's that interrelationship between person, environment, and behavior. One influences the other, and it's that sort of dynamic, kind of like back and forth, interrelated influence. So that's the single best answer that describes the construct. And I think person, environment, behavior, those three are pulled straight from social cognitive theory. Recall definition, what reciprocal determinism is.
I'm gonna wrap this one up in about 5 seconds, just so we can get to the last one and give Alexa a few seconds at the end. Okay. This one, A, is our top contender, 79%.
Yep. And I think this actually goes back to a question that someone asked before we got to these. So let me see if I have, yeah. So this is sort of application of understanding what both of these are and then how they relate. And I know that I did explain the theories in the context of the social ecological model, but as that question did ask, right, what is the difference? And so it's really that social cognitive theory is another way of thinking about the person, but then also environment and behaviors and whatnot. So that's the best answer here, is that both of these sort of like social frameworks think about internal, individual, and external factors. That's the correct answer here. And I think we have one more.
One more.
Yeah. Thanks. You all are doing really great.
Yep, this is our last one. Oh, are you not seeing the poll? I'm sorry. Here, let me relaunch it again. Okay. Thank you. We've got a bunch of A's in the chat, so I'm going to leave this open for about 15 more seconds. 5 seconds. Okay, 94% said different rates.
Yep, going out on a great note here, as we have gone through all these practice questions, that is the correct answer. We looked at the bell curve and saw that people, there are 5 different categories, they adopt at different rates. And I think this even is just sort of intuitive based on how we know people, different people adopt. So it occurs, a rate of adoption is different for different groups. And those are all the questions, the formal questions that I have put together. Thank you everyone for your engagement over the past 2 hours as we've gone through different definitions, examples, your questions, my questions, and so on. I know that like I said, we didn't have a lot of, like, you were just sort of given this information and then we'll ask questions about it. So of course, this does not constitute all the studying that you're going to put into these different theories. So what I recommend doing is really sitting with them. I like that, like, what these theories are very like visual, and you can look at them and understand sort of like the flow. Okay, if I'm moving from here to here, what inputs constitute the outputs? So my recommendation for sitting with this for the theory section would be to kind of have your visuals out, think about the different elements that go into them. You can refer to the definitions that have been provided. But then also beyond that, think about sort of the like intuitive application and thinking, okay, susceptibility and severity, and what does that look like in context? And that's why I'm encouraging you to apply examples and think about, what you may have encountered in your coursework or in your public health practice, that of ways that you can apply these models, because it's going to be important to understand definitionally what goes into them. So definitely recommend taking time to sit with it, but then also the application, I think, is just as important. And I have my email up here, so please feel free to reach out if you do have questions, because I know that we're coming up at the end of our time here. And I really thank you for the opportunity today to chat.
Well, thank you, Alexa, and thank you everyone else who joined us. I hope you will be here on Thursday for our next section. So we'll see you then.